so that as part of the capacity building competition will be one of the training. Is that what you are saying? Okay.
I'm supposed to continue. Okay, just make it easy for me, okay? I read the heading, then we let the okay. Yes. Okay. So where are we? For communication. We have to develop ICE materials, like information communication education materials, centered around specific newborn areas of interest that we know if we're in our mortality. And I think we have partners even outside Ghana Health Service to help us do that. Okay. Oh, we agreed. It was a pamphlet. Let it flow. The ideas. Oh, okay. So my boss has given me a guide. So that should make matters quite easy. No, IEC. So it's not IEC. So let's go with BCC. Okay. Now here ICC. So it's BCC. Communication materials. Okay. Under communication. Communication, whether we can define it better, because we just discussed even between agencies and bodies. So we are not just looking at the community or within the healthcare providers. So communication, I don't know how we are going to couch it, but interagency communication and collaboration or something like that. When we meet in groups, then we can come up with something to define it better. Interdisciplinary or interdisciplinary and transdisciplinary. You can use all of them: intra, trans, ultra, disciplinary, all of it. I think the import there is between those in PDIS or neonatology and those in obstetrics, and even within PDIS. We have internal consultations. So if your baby has respiratory issues for a long time and you're a neonatologist, at some point you have to involve a pediatric neurologist to consider other things that may be out of the scope of our usual RDs or its complications. Okay. And so maybe other subspecialties. Any other comments? The health financing. It's as if no one wants to touch it. The money part. It's just money, just make it available. And all these other things. Who is this? government and partners? Or now we should lean more towards government and partners? Okay. So we have to look at funding options, maybe the broad one funding options. And then the first one will be government budgeting for newborn health, and then specifically for prematurity. Okay. And local resource mobilization. I wonder where this local resource, I'm here thinking these districts that have found other ways to get money from the gold, will it fall under local resource mobilization? So some of the districts have started receipting for the galamsey, the district assemblies. So local authorities. So it will fall under the local resource mobilization. Okay. At least if they are going to take some of the money from the distraction environments, some should go into newborn health. That's what you are saying then. Okay, see that's what you are saying. So just leave it as local resource mobilization.
The government allocated money to the district assemblies to build chip compounds and all that. But nobody went to say that create a space for new. That's the point.
So the health fund that's allocated to the districts, some should be assigned. Yes. They have a term for it. Is it districts common fund? Is it still the case? Okay, so district common fund. So let me put district assembly common fund. So let's specify that one. So that if national even budgets for it, then some is allocated to the districts, we can still allocate, have some of it directed into. Okay. Championed by the districts Our time is up. Have we covered every 2 more? Okay, please come in.
Yeah, can we advocate for some financial policy on free newborn care? I think the money we're told that in some countries like Malawi, care for the newborn is free, so that the family will not say, because I don't have money. Can we advocate for them?
Yeah, I think it should really come up.
Yeah, the government has proposed some free primary health care, and I maybe we can advocate to that concept.
But this one want to be specific that newborn care, because this one is broad, primary health care. It goes continuous, postnatal, CWC, room visits and all that. But this one we want to say that free newborn on the natal care. So that if the woman is discharged home and is she should say that we need scanty for.
Advocating for a free newborn care package
At all levels.
We want to separate it from free primary health care. We should just champion free newborn health care package at all levels. That's what I have. Someone is asking who pay for it. Who pays it? That's why it's an advocacy. I don't know that once we are able to establish that currently we are losing so number of babies and there are coming these complications. And the health economics people are there. They will help us project fees. But this is certainly where solutions.
A lack of newborn care package as well. So that when we get to the stage of proposing solution, we'll now bring in the advocates for.
that is well noted. I think we'll work it backwards to identify the problems so that we're able to move. So those that are solutions or suggestions, when we are going back to this document, we'll make them as problems, and then when we get solutions. Can we look at the next head? Dr. Madion says something. So the problem here will be our low breastfeeding rates, declining breastfeeding rates. As for breastfeeding, we can put it out here in the financial, but yes, under the clinical aspect of outcomes. Someone says financial, it's not true. I can prove it, but yeah, I'll leave it. So we'll take a last comment on the communication, right? Or you want to go to the next heading for us?
I want to mention lack of NHIS coverage for the newborn care. A lot of things NHIS doesn't cover. But for newborns, 28 days, I know automatically when the mother has NHIS, it automatically covers the child. And so if the care of the newborn, NHI takes everything. Somebody asks about how you need to cater for the cost. If it is put into NHI, then we can have a sort of free newborn care for them. So
actually, just by information, it's the implementation part, okay, and then these whole top-ups. So at the end of the day, if the facility doesn't have those basic resources, then now the family will have to pay out of pocket. So I think it will still be under the
movements the baby has, regardless of whether his mother is insured.
exactly. So that's what probably you are championing for. And it's still the case, but it's just the implementation bit. I guess when the TWG meets, we'll probably delve into it and offer practical steps beyond just the general service delivery. No. The NHI will be captured under the newborn health and emotions. Okay, service delivery challenges. Better Susie. Oh yeah, I'm in for this one. Let's hear from the clinicians. This one, people just listen. For better Susie, service delivery, the challenges or gaps. Okay, let's start from there. My God, this one, I won't say this. She said we should see all those that Yes, so that we have a certain flow. So we mentioned the antenatal. So we have even prenatal issues and then unresolved antenatal issues. I think when it's TWG, we then can go deep into the specifics. So let's put this broad. Then I'll add the skilled birth attendants, skilled labor monitoring, and then the natal. Okay. So prenatal and then antenatal care services or challenges with prenatal and antenatal care services. And then we go to, so we still have issues with lack of skilled birth attendants and intrapartum monitoring. So beyond that one, so beyond the labor monitoring and postpartum resuscitation. So neonatal resuscitation.
I have a question about the lack of skilled birth attendants, because with a lot of their skills, the problem is with us in the healthcare system. These are trained nurses. These are not the CPAs and police.
inadequate. Inadequate.
It's beyond training. When you train and you don't support them to implement, they can't do it. It's beyond training. So inadequate training and implementation.
Okay, so I think we've gone to inadequate training and
beyond training, we should really still specify the competency. Someone goes for a workshop, comes back, the person has certificate, so technically the person is trained. But it's totally different from the person now, skill, trained. But it's totally different from the person now, skill, the competence to do it.
I'm not saying that sometimes you think of it from that perspective.
Okay.
I'm not saying that I agree with the problem that people are in. So what are we going to?
You train
Go
support
back to
and
training.
also
You were saying that training was. What do you think?
Certified competence. So in South Africa, so there's a certification. So there's a certification for training, and then there's a certification for competency. That's what South Africa does.
So competency, lack of competency training.
So for example,
for instance, like house, for instance, in certain hospitals abroad, you can't work in the pediatric emergency. You haven't renewed your license in pediatric advanced support every 2 every 3 weeks.
That's what you want to do.
certification for competence.
Newborn resuscitation, pathway vaccines. Even though the team through their midwifery training, they have just assistance skills. We need to keep on ensuring that they
Lack of specific competence. So I think we have lack of specific competence.
And the solution would be certification for having those competencies. Certification for those competencies.
Sometimes you don't have this environment to talk about going to the wards and doing kind of resuscitation kids there. So you need to also make sure part of the training is supervision of entry. You have the environment.
Clinical mentorship will be a solution.
Training, mentorship, and enabling environment. Without that, you can't do
And directors action now, clinical mentorship. So beyond the training, competency, everything, there should be ongoing mentorship to identify the evolving challenges. Okay. Health workforce. Oh, but we talked for under better physio, CC. Yeah, CC. We are not going to talk about any new set of, only there's something very specific about better physio in terms of health workforce, what we need, which is different from prematurity. I can't think of one right. Okay, so under health workforce, the workforce. Hospitals.
So let's address it very well. Apart from the fact that it's a competence level, what else is contributing to it?
Sorry, did you just say collecting us one city?
Because sometimes it's not only apart from the space issue, it's also the contribution. And they are contributors.
And I think sometimes in facilities where you have the different things, you have the OBGYN
capture that. I think for all this, even sometimes it's not just about the number of maybe OBGYN, but the disconnect. How do we capture it in the health? How do we capture that? Because that sounds like the main issue at the higher levels where the human resources are there, but they are not working. There's no cohesion between the teams. So the lack of cohesion between
Escalation. Risk assessment.
I want risk assessment. I want to, however you try it. No. Lack of cohesion will stay. And then inability of the healthcare workers to do a proper risk assessment to determine escalation of care or to guide escalation of care.
Sometimes also the decision to actually act is slow. I mean, we've seen
To
several.
carry out risk assessment.
When you look at the decision when it was made, it was late, and when actually went to actually do this, so sometimes there's the decision to actually intervene, I think I'm making it, and then actually act. It's a big problem. That's so you have the staff, you have the sales staff, but the decision. Sorry? I don't know, this is about every hospital. Yes,
You probably diagnose a woman has antenatal hemorrhage. But by the time being, there's so much delay.
Good quality antenatal services. Typically, for example, a woman would say and is attending a lower facility and will not refer this woman on time or will not speak on time. So it's antenatal, good antenatal plus interactive monitoring and decisions. Yeah, the ones that will help us.
That will go back to the service.
We have to separate them.
Separate them.
Okay. Separate antenatal. Okay. Antenatal. And then I think it was separated from the labor aspect. So I think we'll tease out the details.
If I may agree, that intrapartment when the baby is born, quality antenatal resuscitation.
Yes, I think that's how we capture it. We capture it in the same.
If I heard you right, it was someone that from the way it was done, I saw something about the lady, the design, the startup of the business.
The structure, the setup. What about it? Like theater is 2 kilometers away. It's just small, the space. We need bigger space. So we need to upgrade our infrastructure.
Tend to have only one theater for all cases, whether it's hospital or it's surgical. One theater. So if there's some accident case going on, it comes in. Yeah. Sorry? What if I just have one theater? So
It
it's
sounds like we have
surgical, gynae,
what's happening here, so you can have one discussion. It sounds to me that even when you have a limited space, you don't have enough beds, theater beds. That is the issue. Is the women will come one. That's not the issue. We never come up as an issue till there's a surge, and usually it's an emergency. So we have an emergency response infrastructure that normally doesn't match the surge in the need or something like that. So though we agree that, and everybody everywhere, if you ask what do you want more, everybody wants more space, more everything. But the challenge really is that you have 2 theater beds to respond to emergency, and you have 5 emergencies. Is that what is happening? Okay.
Typically, we can do maybe one C-section at a time. If there are not enough anesthetists.
So inadequate infrastructure. Let's capture all that as infrastructure. Inadequate infrastructure to respond to emergencies. To respond to emergencies. And that's why maybe we've identified that this woman has developed a complication, needs emergency CS, and yet has to wait. And then it leads to death asphyxia. Okay. Different.
The challenges are based on so if you have a woman coming and the chest contract,
We don't need them to have a scan. We need them to be able to identify that this matter has to be moved to a hand. So community, there should be a part where we capture community. Because that will match what service you can deliver at every level, and then that will lead us to. Okay, so those are two different issues.
So what I'm saying is that it's a continuum. By the time there's a delay at Chief's compound, the game is over. That woman finally ends up at the district hospital.
And we are saying the cause of that delay is. Okay, so multifactorial causes of delays. And then we'll tease out the factors when we go into TWG work. Yes. So multifactorial causes of delays in the facility. Because if you look at even the current training that we are doing to review maternal and perinatal deaths, we are separating the delays. Okay, the first level of delay that's happening at the community or the caregiver level, we need to separate it from what we are describing right now. Right now, we are seeing that the woman trusted us came into the health system, but there are delays, whether within the facility in recognizing that this is a high risk or a complicated labor, or this is a high risk or complicated newborn, and then outside between the facilities there are delays. Okay, so delays, so multi-level.
And that's where they are putting obstetric triage. It's a brilliant project. Ghana is ready to swallow that.
So we will come to solutions. So let's capture that under solutions. So multifactorial cause of delays within the facility and between facilities. Within and between facilities. And the solution is the Otis. Wouldn't all these things, okay, be resolved if we're able to tease out the levels of care and a resource at every level?
For resuscitation corner, when you are conducting resuscitation, even if it's a health center, you should have resuscitation.
So we want to separate it from this one, and lack of resuscitation corners or in the delivery room. Let's start with that.
It's a table.
Lack of resuscitation corners in the delivery room. So no scoop and run.
Written bad things and
We would refine the terminologies as we go.
bad things also in corners.
So resuscitation corner or slash station.
One is
Slash
we don't
station.
want corners.
Corner always feels like we are pushing the new like
They're doing something bad.
that's a very exactly corner.
Yeah.
The corner.
Yeah,
Station.
exactly.
Station has a certain importance
Exactly.
to it for us to resolve the problem. And the corner I always felt like, okay, no, take care of the matter, take care of the matter. Just get a corner for the baby. We have to disabuse our minds. No, station.
Big space.
So, no, I can't answer this alone. So I think it falls under service delivery, but specifically they are supposed to help us with our referral pathways, strengthening the referral pathways. So I think I'll capture it still under service delivery. Okay, and then poorly, I won't say poorly trained EMTs because it's not fair. But how do we capture it? You know what I'm talking about. Or like, but see, the attention is on neonatal care. It's not that they are not trained. Okay.
Yeah.
So inadequate neonatal care trained EMTs.
Or maybe we can say
When we are referring,
We will refine it and come up with.
there should be coordination so that when we are referring, then we don't necessarily need to train these people, but a service provider will accompany the woman because earlier in the morning to just
I have to comment on this one.
in the morning there was a presentation that when we are referring this unit, the ambulance who are not allowed the midwives to accompany them because they think that they have enough training. Yes, so that's what I'm saying that to coordinate so that at least there will be that advocacy that when we are referring associated to they should know that it's about them. So a midwife or somebody, especially somebody who have more knowledge of skills
Okay, please can we quickly align on this? Because from where I sit, there are two sides. You have a group of EMTs who feel or who think they have been trained enough to resuscitate or provide care for associated babies or all newborns. So that's the first group. By virtue of whatever training they've been exposed to, they feel they have the competency to safely transport newborns no matter what condition they have. And then we have another group who insist that you must provide a midwife or a nurse or a doctor to accompany them. So it's not just one side, it depends on where you find yourself and then the confidence of the EMTs. So either ways, we can agree that the EMTs need to be trained to provide adequate newborn resuscitation and refreshes. Okay.
Back along the ambulances are not situated to support that.
So inadequate neonatal friendly ambulances. Okay. Under 70. Okay. Can we move to the other headings quickly? You know we have the last major when we say midwife handling the mother who is also at all levels, that's how it's supposed to be.
At all levels, but
To receive the baby.
the church compound, I don't know how practical most of the church compounds are asking to is just one midwife and a public health nurse. And sometimes the public health nurse is out doing outreaches, so the midwife is alone. So she is providing the care for both mother and baby. Unless of course we have to now post more midwives.
And that's what I was going to comment on. Okay, we need to separate states.
How the midwife who comes to receive the baby, is she adequately trained to be able to resuscitate the baby where
Wife. When you say midwife, everybody's mind goes to the one who takes care of the mother. And that has been our challenge. Midwives are trained to provide care for the mother. And
Yes, and the baby.
and the baby.
Yes.
Regardless of where the midwife finds yours.
Midwife is supposed to
You see,
there should be one person who's sole responsibility for resuscitation. And that person should be able to initiate the resuscitation.
So let's give a title to this person. And usually,
Not Ray, you call them that team.
oh, that is boss.
the DAT team. Okay, so let's look at it at all levels. We want, I think they're saying the same thing. We want a staff dedicated to provide care for the mother and one dedicated to provide care for the baby. But in our current human resource structure, and I don't know what we are going to propose, we don't have a title solely for the one who is supposed to provide care for the newborn. It's not the midwife, that's what I'm saying. So if we are going to propose as a technical working group later, that then we need to have a title.
The person whose sole responsibility is the baby will not be a midwife. It can be a midwife, but need not be a midwife.
It can be another nurse. But we need
Who has been
Who has
trained
given extra
to
training?
provide.
to initiate
Okay.
the resuscitation?
Let's take note of this. This is important.
What we are saying is that if we go to a chief's compound and we have just one midwife and we have one public health nurse, that public health nurse should know how to resuscitate,
Initiate.
to initiate. So as the midwife is sorting out any complications in the mother, that other
Yeah.
The baby may need only just
And I'm saying that till we come up with a description, okay, we will all suggest it, everybody will understand it. But when it goes to implementation, the person playing the role, who will step up, it will be a challenge because the person's title is public health nurse.
No.
So, okay. All I'm saying is I'm standing here thinking that we need to have a title so that the person knows that, okay, in this unit, even though I'm a public health nurse, but when it comes to delivery labor, there's a midwife, and then there is me that I will call upon to provide the neonatal care. Someone said baby receiver. Please note it down.
Baby receiver.
So we'll take a comment from Jenny, we'll take a comment from here, then we'll come to you. Is that okay? So we'll talk things together.
Yeah, I'm trying to understand what you are saying. And as chief compound delivers June, coming back in a month. And I'm saying that, are you saying that the person's sole concern should be that
Only for
the person will be assigned per delivery. So that if it's a delivery, then it's just a focal person for. So that will be in a way we disagree.
I don't like So, newborn resuscitation focal person. Let's note also. Please note it. Newborn resuscitation focal person. And that one, it doesn't matter what your official training is. You can be a doctor, a midwife, a nurse, public health nurse.
You must be trained.
You must be trained. So, newborn resuscitation focal person. And we don't have to create a new office. It's already, whoever you are, we'll just catch you and make sure you are trained to provide and complement a midwife. Okay. And you can be a midwife. It doesn't matter who.
At that level, because that's also another different thing. So at some point you have one person, other places you have a team. So it has to
So newborn resuscitation focal person / team.
another very important thing is that any place delivery occurs, the people there working all ideally should be trained to initiate the data resuscitation.
But because of complexities and because we have very premature babies, we don't want every single midwife to do NRE. We don't understand that. Therefore, it's best way to have a few people who are designated, who you know will assist in delivery. Now, at the
So that's the reason why we have advanced neonatal resuscitation. And then we are saying HPV. I understand.
So that's why for me, the resuscitation where it goes on enough. Clear as we say, according to the levels.
Okay, the levels. I think we are clear. I think we are seeing the same thing at this point. But the implementation. Next slide. Skip. Let's go to health finance CC. Okay, CC. Yeah. Community awareness. Community awareness. Health finance. So lack of not just bad awareness, right from labor to resuscitation. So lack of neonatal resuscitation equipment, which are other commodities. Okay. 70 people.